Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again, and welcome back to the Bridge to Health. My name is Dr. Tom Dow, and I have a quick question for you in the audience. Do all of your doctors that take care of your health needs communicate with one another? Most of our patients, before they come to us, say they don't think so. So, years and years ago, the Civil War, the Roman Wars, the Greek Wars, the strategy of the different armies was the first thing they want to try to do is to kill the leader, to try to kill the ruler, to try to kill the strategist that was able to orchestrate the battlefield. And the reason why they did that is because once the leader was killed, it usually turned out to be chaos amongst the other warriors. Of course, no one was telling them where to go or what to do. In our healthcare facilities, our 4 locations, we have a team approach. When you come and see us, we treat the whole person from head to toe. We look at you, we examine you, we make determinations on what other healthcare professionals you need to see for the benefit of your health. And as a team, either in our facilities as part of our team, or doctors we have outside of our facilities that are part of our team, we all work together as a team with a plan to give you the best possible health care possible. Today, one of our team members, who is not in our office, but outside of our office, who we work with regularly, is Dr. Paul Alongi, spinal surgeon. Welcome, Paul. Thank you for coming.
Thanks for having me.
No problem. Paul, where did you go to medical school?
I went to medical school at Downstate Medical Center, which is in the East New York portion of Brooklyn.
Okay. And how many years is that? 4 years?
It's a 4-year program, and Downstate has a good program in terms of a lot of hands-on experience, and it was a great learning experience for me.
Right. And then after that, you did a residency, right?
So after I graduated medical school, I did a general surgery internship at Westchester County Medical Center, which is in Valhalla, New York.
Mm-hmm.
That's for 1 year.
Right.
And then after that, I did my 4-year residency program at Monmouth Medical Center, which is in Long Branch, New Jersey.
Uh-huh.
So upon completing my orthopedic training, I did an additional year of training in spinal surgery fellowship at the University of Colorado in Denver.
Wow, wow. So in that 4-year residency, was that all spinal surgical work? Was that your specialty?
The 4 years of orthopedic residency is a combination of all different types of orthopedic surgery.
Okay.
So there was some spine, fair amount of spine, but there was also sports medicine, total joints,
right.
fractures, the whole spectrum of orthopedic.
And then the year you did after that, extra, was just spine?
Yeah, the following year, which is an additional year of training, was just a fellowship, and it concentrated strictly on spine.
Excellent. And where do you practice now? Where's your office located?
My practice is Orthopedic Spine Care of Long Island. We're located on Jericho Turnpike in Huntington. We've been there since, the practice has been together since 1999. We've been at that location for the past 5 years.
Right. And are you there just doing spine surgery, or are there other healthcare professionals in there working with you with doing different things?
We are a spine care facility, so it's a state-of-the-art facility. It allows us to treat anything from the neck to the back. There's surgeons, orthopedic surgeons, but we also have pain management doctors and imaging available as well.
Right, so you have MRI there. You have CAT scan there too?
Yes, we have X-ray, we have fluoroscopy, we have CAT scan, we have MRI.
Right, and you have a pain management doctor there, Dr. Qureshi, that does spinal injections, right in your facility, right?
Right in the facility. We have fluoroscopy suite, which we can do the injections. Some patients have a difficult time with the injections, so we can do them under anesthesia with sedation.
Right.
And so it's comfortable for the patient.
And I've known Dr. Alongi for many, many years, and he is the type of doctor that, as a last resort, resorts to surgery and tries every conservative mean first. Isn't that right, Paul?
Yes. Majority of patients with spinal conditions can be treated non-operatively. And that really begins from the first visit, and we kind of emphasize that with the patient. So patient comes in for the first time, again, we'll evaluate them, do the appropriate testing, and again, majority of patients, we start with non-operative treatment, unless they've already gone through a significant amount prior to coming to us.
Right.
So, I
So
mean,
you'll recommend like physical therapy, you'll recommend
Yes.
chiropractic care if necessary, massage therapy, things that will help the patient maybe get better without having to be operated on.
Yes, definitely. Usually starts first with just trying to get their pain under control. We do that with medication,
Right.
anti-inflammatories, muscle relaxant, and then, home exercise, chiropractic treatment, physical therapy, acupuncture, massage, all that contributes to the patient's recovery.
Excellent, excellent. What types of conditions do you treat in your practice?
We treat pretty much any condition involving the neck or lower back from the base of the skull all the way down to the coccyx or the tailbone.
Right, right. But I mean, what types of conditions?
It
People-
varies. We'll see strains and sprains of the muscles. Typically, when patients have minor car accidents, their body gets whipped one way or another. I'm sure you see
Yep,
hundreds
yep,
of those patients.
yeah.
They may not have a fracture, but a lot of times they'll have a strain or sprain of the muscles, and we'll see patients like that. We'll see patients who have conditions in the discs, either a herniated disc, where they can have a pinched nerve, which
Right.
may result in either arm pain or leg pain.
Right.
Typically called sciatica.
Right, right.
And we'll see patients like that. Some patients have more degeneration of the discs, and we'll take
Right.
care of them.
Right.
And then, more extensive type conditions, deformity of the spine, like scoliosis, spondylolisthesis, we take care of that.
Right, right.
And even some of the more serious conditions, we'll take care of tumors, infections, and fractures of the spine.
Wow, interesting. Yeah, so, many times we have patients that have had car accidents or falls and slips, and they have what's called soft tissue injury. So we'll begin to treat them, and thank God, knock on wood, most of them we get very, very good results with. But there are times when the injury is severe enough where they may have a big disc herniation, putting pressure on the cord, that thank God we have somebody like Dr. Alangi that we can send them to. So what I'd like to do now, Dr. Alangi, is I'd like to talk a little bit more about disc herniations.
Sure.
So can we have the first slide, please? And Dr. Alangi will speak about what a normal spine should look like from the front and the side.
Sure. So looking at this diagram, you have two views. You have a side profile and then the frontal profile. So when you look at the spine from the front or the back, it's typically straight. But when you look at the spine from the side, as you can see in this diagram, there's normal curvatures of the spine. In the neck, there's a normal curvature called lordosis. In the upper back, there's a normal curvature called kyphosis. In the lower back, there's lordosis again, and then the sacrum is kyphotic. And so you need these curvatures to really help balance the head over the pelvis and help distribute muscle forces appropriately for an upright posture for walking. And the spine can be broken down into the different segments. The neck, which is the upper portion of the spine, is the cervical spine. There's 7 cervical vertebrae. In between each vertebra, there's a disc which help cushion the vertebra. And then going down lower, there's the thoracic spine. There's 12 thoracic vertebrae. And then the lumbar spine, there's 5. And then the sacrum and coccyx is kind of all fused together.
Called the pelvis.
Pelvis, yeah, part of the pelvis, yes.
Right. So, yeah, we often tell our patients when we first examine them if they have a loss of their normal curve of the neck going forward, their lordosis, that the reason why we have these curves, these 3 curves, is because those curves act like a spring to absorb shock. They actually flex a little bit as we walk or as we bounce up and down. And then once we lose those curves, which is the first phase of degeneration, now you got the head pounding on the vertebra without any shock
Sure.
absorption, which leads to the degeneration, which we're going to touch on. Can I have the next slide, please? Slide 2. And we have here a lateral lumbar spine. Dr. Alangi, talk about the herniated disc you see
Sure.
there.
So this is a lower portion of the spine, the lumbar spine. Again, you have each vertebra. In between each vertebra, there's a intervertebral disc. Now, if you look at the mid portion of the diagram, it's like L23. There's a projection posteriorly.
The blue
The
thing, yeah.
blue material. That is representing a herniated disc. So the disc is a circular structure, and in the center of that disc is what's called the nucleus, and either from an injury or from different activities, that nucleus can herniate out. And the issue with that is it's very painful, and there's nerves close by. As you can see in the diagram, where that disc is right in the neural foramen where the nerves exit, and it causes a pinched nerve and a severe amount of pain.
So if that herniated disc, that blue structure you see popping out, which is hitting the nerve root, if that nerve root's going down somebody's leg, they may experience sciatic pain,
Oh, yes,
pain in their
definitely.
butt, pain down the leg, because that disc now has broken and hit that nerve root.
Yeah, so the disc is you're pinching the nerve.
Right.
Like you said, it can have pain all the way down to the foot. You can have numbness.
Right.
Some patients, it's severe enough to have weakness. And it can be very
Cramping
severe symptoms.
sometimes, right?
Exactly.
Right, and can you go to the next slide, please? And there's another example of a disc which is popping out, hitting that yellow structure, which is a nerve root. Next disc, please. Next slide, please. And talk about that one.
Again, it's another diagram showing the disc in relationship to the nerves in the spinal canal. So you can see the structure looks a little reddened on this diagram, is pushing out of the intervertebral space where it's supposed to be, and it's putting pressure on the nerves. And the nerves are housed in a canal, and there's a roof, what's called lamina, and so there's nowhere for that nerve to go other than getting pinched with that disc, and it's very
Right.
painful.
You know what's interesting, which I discovered years ago, which is a lot of people don't realize, is the disc fibers themselves, the annular fibers, actually have nerves within them. It's called, what's the nerve called? Siniovertebral nerve or something
Yes,
like that?
yes.
Siniovertebral nerve. So you can actually have torn disc fibers and not see a herniation on an MRI, which could cause low back pain.
That's correct.
Right.
You know, there is nerves in the annulus of the disc, and if you tear that annulus, you can have pain. There's also a chemical reaction that happens with a tear, and that chemical reaction can irritate local nerves
That
as well.
causes inflammation and
Exactly.
everything
It'd be
in the
very
area,
painful,
right?
even though there's not an actual
Yeah, so I
herniation.
think that's really important for you folks out there, that if you've been to a doctor and had an MRI done, and the MRI your doctor said was negative and there wasn't a herniation, that doesn't exclude that the disc fibers may have been injured, and there might be other tests which could show that, which might explain why you're having your back pain. Can we go to the next slide, please? Okay, now this slide is a slide which, from the upper left side going to the upper right side, going down to the lower left side, going down to the lower right side, shows the progression of different types of disc conditions. I think the first one up on the top left probably is just a bulge, right, Dr.
Yeah, so
Lange?
this is a cross-section looking down the top of the spine. And so the disc is up front, and behind the disc is the nerves.
Right, so
you-
this is like actually cutting your body in half
Exactly.
and looking straight down,
Exactly.
right? Right.
And so, yeah, that first upper left-hand image looks more just like a bulge where there's a slight protrusion of the disc. And as you progress to the right,
Upper right, yeah.
Upper right, it's a little bit more pronounced, and as you progress to the lower left and the right left, the lower right, that disc herniation gets larger. It's more extruded and pressing the nerve.
And sometimes that disc part material can actually break off the disc, right?
Yes, that's what's called when the patient has a severe enough disc herniation, they can have an extruded fragment which comes out of the disc space,
Right.
and it's in the canal as a free
So now that little opening, that canal that nerve root goes through, that disc is trapped in that canal. And when we have a patient in our office and we do an MRI and we see something like that, with us, in our practice, it's immediate referral to a spinal surgeon such as Dr. Alangi, because you don't want to be manipulating or moving things around with a disc that's broken off inside a canal. So that's why we have great docs like Dr. Alangi to help us with this class of patients. So what do all disc herniations require surgery?
No, majority do not. Initially they're very painful, and we could usually take care of that with medication, at least reduce the inflammation. If there's any spasms, help reduce that with medication,
Right.
and help with the pain. And again, other treatment, chiropractic treatment, physical therapy, exercise,
Right.
all that helps and reduces the patient's symptoms. And the majority of patients respond nicely to conservative treatment and do not need surgery.
Do all disc extrusions and fragments require surgery?
No. It's amazing. There's some patients I see in the office, and they have a tremendous disc herniation, and you tell them, most likely this is going to need surgery. But we'll try conservative treatment, And I'm surprised a lot of times where they do respond nicely to conservative treatment
Right.
and their symptoms get better. So it's really hard to go just on the MRI if they're going to need surgery or not.
Do you ever look at an MRI and once you get in there and open somebody up, you find things that the MRI didn't show?
Sometimes MRI is a great study, and it shows a lot of detail, and it gives you a lot of information before you go in there. Occasionally that will happen, seems a little more extensive, or since the MRI was taken, additional disc material can herniate or
Right.
extrude and be present when you at the time of the surgery.
Do you ever see patients that have had disc surgery and then 6 months, a year later, 2 years later, that disc herniates again?
Yes, I tell patients when they have surgery for a discectomy for a disc herniation, there's about a 10 to 15% chance of a recurrent disc herniation down the road. It could be days later, it could be weeks later, it could be years and years later.
So when you're actually in there operating on that patient and that disc is herniating out, what are you doing? You're just cutting off the part that's herniating out, or you're cutting out the whole disc?
Yeah, we just when we expose the disc and the nerve. So the nerve is retracted and it's protected
Right.
with an instrument, and the disc herniation is pretty evident usually once you retract that nerve root. And we just pull out that fragment. It's pretty much a free fragment. It pulls right out. We go into the disc space, make sure there's no other free fragments, and that's it. Majority of the disc stays in place.
But you don't have to
You don't-
sew up the disc where it was
No,
broken or anything
that
like
just
that?
scars up. That's a good question. A lot of patients ask that. That's just allowed to scar up. The annulus scars up, but the majority of the disc stays in place. I mean, if we did take out the entire disc, with some procedures we do that, then we need to do a fusion because there's no disc left and it's
Yeah,
more
which
expensive.
we're going to
type
talk
surgery.
about that on our next show, the different surgical techniques that Dr. Alonji uses for different conditions. So, you have a patient come into your office, and you constantly are in communication with the referring doctors. I know because I get
Yes.
your reports. Your recommendations are great. Is that how it was 25 years ago with alternative doctors?
Not really. 25 years ago, you had your spine surgeons, and they had one way of treating the patients, and there's the chiropractic and alternative treatment providers at the other spectrum.
Right.
And very little did they
Did they talk to
intermingle.
one another?
Yeah. Nowadays, it's very common. I use it a lot. A lot of patients do benefit from different treatment modalities. Some patients benefit from therapy, but then other patients benefit from chiropractic treatment.
Right.
Some patients don't benefit from either of them, and we do acupuncture, we do massage. We try multiple different modalities to help with the patient.
Which is why it's optimal to have your team with many different specialties, all either in the same location or close by where they can talk to each other on a regular basis. So the patient can basically get a la carte from that healthcare menu to give them the best chance of having full recovery. And one of the things that we explain to our patients is that if you have two vertebrae, which are, you're looking at the spine straight on, and you have two vertebrae which are parallel to one another, that's how they should be, and not wedged, that if the person has a trauma and they have a car accident or a fall, and those vertebrae now get knocked out of alignment or wedged, in chiropractic we call that a subluxation, that now with that wedge and the weight on top of that top vertebra, that disc has to go to that open side of that wedge. So one of the treatments we use in our practice called spinal decompression or flexion distraction technique, we actually traction this space open with our hands with a special table, and then we laterally flex the table to the side to try to close these vertebrae and close this wedge so this disc has a reason to go back where it should. This works very well for certain types of disc herniations, absolutely not for extrusions or fragments or really big herniations. But we do get some success in reducing the size of that disc sometimes with this type of treatment. All right, so can you tell me what a laminectomy is? Tell the audience what a laminectomy is.
So the spinal canal is covered by what's called the lamina. The lamina is just the roof of the spinal canal. It protects your nerves. Occasionally, you get pressure on your nerves, either from a disc herniation or from stenosis, and so the canal where the nerves stay is tighter. So it's putting pressure on the nerves, it's painful. So when patients have this condition, called spinal stenosis, again, a lot of times they can be treated non-operatively with different modalities, but sometimes nothing helps and they elect to undergo surgery. And surgery is a great option. Patients tend to do very well because once you relieve that pressure, the nerves recover and it helps with their symptoms. So a laminectomy is just we remove the lamina, which is the covering of the nerve, to make more room for the spinal nerves within the spinal canal.
Right. And so you talked about stenosis, and the way I explain that to my patients is that one slide we looked at, which was as if you cut yourself in half and look down, that spinal cord comes up that canal, and if the canal is supposed to be so wide, but now it's narrower, the cord and the nerves don't have as much room to pass through. And yet this procedural laminectomy, so you're actually making more room for these structures.
Exactly. It's a mechanical issue where, like you said, the nerves, when you're younger, there's a lot of room for the nerves. There's no pressure on the nerves, so there's no pain. After the age of 20, you start getting degeneration of your spine. So as you get older, the canal gets tighter. There's the disc starts to bulge out a little bit up front.
Ligaments, hypertrophy.
Exactly. Ligaments from behind,
Bigger.
Hypertrophy. There's facet joints that become arthritic and bigger, and all that kind of comes and encroaches on the canal.
Squeezes everything, right?
And pinches those nerves.
Right. So in your practice with stenotic spines, is there a such thing as congenital stenosis, like where they're born with that?
There are some patients who have congenital stenosis where they're starting off with their canal is a little bit tighter than the average person.
Right.
And that makes them a little more prone to have conditions as they get a little older.
We often tell patients that have been in car accidents after they have their MRIs that their spine is degenerated, it's stenosed, and now they have a herniation, which has made it more stenotic. And they ask me a question. They say, "Well, is this from the car accident, or did I have this before?" And my answer to them is, well, yeah, you had it before, but that doesn't mean the car accident didn't create your problem, because instead of calling it a pre-existing condition, we call it a risk factor. That person is at more risk for injury than the average person. I'm sure in your practice, you've had patients who have been stenotic, and you might have told them, well, if you get pushed hard from behind, or if you have another car accident, you're at greater risk for injury than a normal person would be. Is that right?
Yes, that's right. And like you said, everybody gets some degeneration of their spine. After the age of 20, there's a protein called proteoglycan, which is in the disc itself. It helps attract water to the disc and keeps it healthy. After 20, you start losing proteoglycans, you start losing hydration. That's just normal life, aging.
It's part of aging.
Yeah, and to different degrees in different patients. So everybody has that to some degree. If a patient has no symptoms and has a car accident and now they have symptoms, obviously, to me, it's as a result of the car accident.
Has there been any research or anybody ever tried to come up with something to inject discs to get that hydration back?
There's a lot of studies now going on with stem cells.
Right.
Not so much with the hydration, just regenerating.
Right. Which we're going to talk about on our next show,
tissue.
the different treatments. What is a spinal fusion?
A spinal fusion, there's various reasons we do a spinal fusion. Usually it's for some type of instability where the vertebrae are moving abnormally, and so there's extra motion, which can be painful for the patient. Sometimes it's for a deformity like a scoliosis or spondylolisthesis. Sometimes it's for something more serious like a fracture or a tumor. So what spinal fusion is we're taking two vertebrae, which typically there's some motion between, and we're stabilizing it so it fuses together, so it acts as one piece of bone, and so it's not painful anymore.
Do you do that just if there's instability, or if you have like a 2 or 3 level laminectomy? If you're removing the laminas just for
It
stability?
depends on the patient's symptoms, but typically if a patient has pure leg pain,
Right.
with say from stenosis,
Right.
and on their preoperative X-rays there's no instability, we could just do a laminectomy.
Oh, okay.
But if there's instability, you usually tend to do a fusion.
And I would assume,
address-
I don't know, but I would assume a fusion is a longer recovery than just a laminectomy, right?
It's a longer surgery, it's more exposure, and it's a longer recovery.
What's the longest surgery you ever did? I'm curious, 'cause that's got to be exhausting.
There's been cases, I've done 12-hour cases.
Wow.
That's really extensive reconstructive surgeries.
Wow.
Typically, like a discectomy, a one-level microdiscectomy take an hour. A one-level fusion, maybe 3 hours. And then, after that, it's really
After
more
that, you go home and
extensive.
take a nap.
There's more extensive surgeries after
right.
that.
And do you have patients come into your office with osteoporosis?
Yes, we see patients with osteoporosis. We see a fair amount of elderly patients who do suffer from osteoporosis.
And do you have patients come in with scoliosis?
Scoliosis as well, and that can vary. Some patients are younger, when it's adolescent age, and they're picked up at a school screening. And a lot of patients just require monitoring.
Right.
If the curve is not that severe, we'll get just follow-up X-rays every 4 to 6 months. If it's severe enough, sometimes we'll put them in a brace.
Right.
And as patients get older, they can have scoliosis, and that's due to arthritis.
Right. I have patients come in all the time, and if they've never been X-rayed before, I put their X-rays up, and we have a curvature on the AP film, and I tell them they have a scoliosis. A lot of people think that scoliosis is like some type of disease, but really all scoliosis is when you look at your spine straight on, it's supposed to be straight. All it means is the spine's curved either a little bit or a lot, and the degree of scoliosis, we measure that, and if it gets severe enough, guys like Dr. Alonji or the spinal surgeons to stabilize that, it's necessary because sometimes if that scoliosis gets so bad, can it affect their organs and things
Yeah,
too?
they can affect their breathing, their organs. So, typically, an adult, as long as it stays somewhere under 50 degrees as an adult, you're okay.
Right.
When it starts getting over 50 degrees, that's more of an issue because it's more likely to progress, and that's when we say, as an adult, you need to get that corrected and stabilized.
Right.
As an adolescent, it's a little bit less. It's like to keep it under 40 degrees.
Right.
And usually that's when you require surgery.
Well, Dr. Alonji, I'd like to thank you very much
thank you
for
very
being
much.
a guest on
Appreciate
our
it.
show. Those of you that are watching us on Madhouse TV, stand by. We'll be right back with Dr. Alonji for the next show on his various treatment techniques for different conditions. Those of you that are watching us on Cablevision, we'll see you next time. Have a great day.
time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again. Welcome back to the Bridge to Health. My name is Dr. Tom Dow. Today we have the honor of having a special guest, Dr. Paul Alonji, back for our second show. And on today's show, we're going to speak about the techniques that Dr. Alonji uses within his practice on people who need spinal surgery. Welcome back, Dr. Alonji.
You. Thanks for having me.
So the first question I have for you, we spoke quite a bit on the last show about discs. What is a microdiscectomy? How does that differ from a regular discectomy?
A microdiscectomy is pretty much the standard of care right now for disc herniation. Again, like we talked about the last segment, majority of patients can be treated non-operatively with a disc herniation. Just to give you a little, oversight of what a patient would expect if they came into our office. I saw a patient for the first time. They come into our office, and they'd see me, be evaluated, and supposing they had, leg pain for a few weeks, they just tried over-the-counter medication, and nothing really seems to get better. So typically what we want to do, again, majority of patients can be treated non-operatively. So we start them on medication, anti-inflammatory medication, help reduce the inflammation because that nerve is really inflamed and painful. They may need a little bit of pain medication or a muscle relaxant to help ease any spasms. And sometimes that will help. Occasionally we'll have them do some home exercises, and that may help. But if the patients continue to have symptoms, they may need additional regimen of exercise or therapy or chiropractic treatment, something to help improve their function and help them recover. And the majority of patients do recover and improve with that regimen. Some patients continue to have symptoms, and those patients may get an injection of a steroid, either an epidural steroid injection or a trigger point, and that may help also.
You do those, both of those in your office?
We do those in the office, and patients can either do it with just local anesthetic, or if they're really uncomfortable, they can do it under sedation. And again, the majority of patients do respond to that. We usually like to give the patients at least 6 weeks, if not more, of conservative treatment before considering surgery. But there's a small percentage of patients that go on to have symptoms despite the treatment that we've been giving them. So for a patient who has a herniated disc, a microdiscectomy is a great option. It's a small 1-inch incision through the lower portion of the back. We go down, we just expose the nerve and the disc herniation and pull out that fragment that's pinching the nerve. Patients tend to go home the same day from the surgery.
So you're not cutting the lamina, nothing, you're just going
No,
into
really
the
just, there's a ligament there called the ligament of flavum that covers the nerve. That gets detached. Occasionally, depending on the level of disc herniation, sometimes you got to trim a little bit of bone just for exposure of the nerve root.
Right.
But once that's done, the nerve's exposed, it's retracted and protected,
Right.
and it exposes that disc herniation. That's removed. Again, just 1 incision. Patients go home the same day. Typically, I tell patients, if you have a desk job, give yourself 2 weeks, but a lot of patients can go back sooner.
Wow, that's pretty fast recovery.
Yeah, it is very fast recovery.
Now, what is just a regular? Is that different than a regular discectomy? What's a traditional discectomy before they had this?
Typically it was just a bigger incision. So
Bigger
it's
incision.
really just the size of the incision. It's a small incision. Some doctors use a microscope. I use
Right.
magnification, which just magnifies the surgical field. But years ago, it was for one level discectomy, it was a big incision. They remove a lot of the lamina,
Right.
a lot of muscle dissection, and bigger recovery.
Right. And remember, Dr. Alonji is an integral part of our healthcare team in all of our offices. And he is the type of doctor that, as a last resort, will do surgery and will try every conservative means first, which we do in all of our offices. But there are times when people do need surgery. There is no other choice, and thank God we have Dr. Alonji for that. Doc, what is an ACDF? What does that stand
So
for?
ACDF stands for anterior cervical discectomy infusion. So again, when a patient has a herniated disc in the lower back, we do a microdiscectomy. You go from the back.
In the back, you do the cut.
And you can retract the nerves and pull that disc herniation out. In the neck, because you have the spinal cord there, it's difficult to go from the posteriorly from the back because you can't really retract the spinal cord. It's too dangerous. So typically for a cervical disc herniation, we go through the front, so it's anteriorly.
So the anterior is the front, audience,
Yes,
and
through
the
the front of the
incision is
neck.
made in the front, and you go in to get the disc from the front.
Yeah, so it's it's a small incision, about an inch. It's a horizontal incision, which heals very nicely with the creases of the skin. There's not a lot of muscle up front, so it's not a very painful incision. This is
You're cutting across like this, so
There's a thin
it's-
facial
you
muscle.
don't really see the scar.
Exactly, and once you get through the muscle, it's a very easy dissection to get down to the front aspect of the spine. That exposes the disc. The entire disc is removed.
The entire disc
yeah,
is taken out.
For a cervical discectomy, the entire disc is removed, and that gets the pressure off the nerves and the spinal cord. But now you have a space there where the disc was. So you need to do a fusion there because there's no more disc left. So the disc is removed, you put some kind of spacer in there, and usually majority of surgeons put a plate on top just to stabilize
What's
it.
the spacer made out of?
I use what's called PEEK. It's a high-grade like polymer or plastic, and in this it's almost like a ring. And in the center of the ring, bone graft can be placed, and that bone will grow from the one vertebra above to the vertebra below.
So
And
it's
it goes
actually
through solid.
fusing 3 vertebrae together.
It's 2 vertebrae, 1 disc, yeah.
Yeah, right, I'm sorry.
And
2
there's usually a
vertebrae,
plate on top. That just helps stabilize the fusion, allows the patient to be out of a hard collar. They're usually in a soft collar for about a week, and that's it.
Wow, that's pretty fast recovery.
And it's another fast recovery. It's usually not very painful.
Okay. And what is spinal decompression surgery? What is that?
So when we talk to patients about decompression, we've talked about stenosis where the nerves are getting compressed, either from stenosis or herniated disc.
The
or
canal's
ligament.
getting smaller.
Canal's getting
the-
smaller.
The cord, the nerves are all getting squeezed because from arthritis, from ligament the ligament's
Exactly.
growing, everything's getting compressed. So now we want to do a surgery to decompress that.
We want to decompress the nerves. And so the bone is causing that pressure. We remove the lamina that's causing pressure on the
back
nerve.
part of the vertebra.
So we're decompressing the spinal canal, we're removing the lamina, any thickened ligament, just getting all the pressure off the nerves to help get with the patient's symptoms.
Now, it's funny because I asked you this question a couple of months ago on one of the patients I referred to you. And I asked you, I said, when those lamina are removed and you don't do a fusion, how come you can't just stick your hand right in there and hit the cord? Because I always thought that, that's what protected the cord. But you said what?
Yeah, I mean, that's the function of the lamina is to protect the cord. It's a roof over the nerves. But I mean, especially in the lumbar spine, the spinal column is so deep. There's skin, muscle. It's very deep to the surface, so you'd never be able to just push it from the outside.
And there's like ligaments and things.
Yeah, everything else
which is
that
still
help
intact.
protect it, yeah.
Okay, cool. So, what is the difference between a full spinal fusion and a minimally invasive fusion?
So, I mean, the end result should basically be the same. A minimally invasive spinal fusion is just trying to limit the incision size.
Okay.
So less soft tissue trauma, less blood loss, less
Right.
post-op pain, quicker recovery.
Right.
So we try to do that in all the cases if we can.
Okay.
Do a milling type of procedure with a small incision, but the idea of the procedure is basically the same, where we're fusing the segment, we use instrumentation, we use bone graft, but it's usually less of an incision.
What kind, is it bone from the patient or is it artificial bone? What do you use usually?
I mean, years ago, we used to use the patient's iliac crest or
Right.
hip.
And that was more painful than
That
the
was,
back surgery.
that was more painful, increased the time in the operating room, increased blood loss, recovery was harder, and, it was difficult for the patients. So about 10 years ago, they created a BMP. BMP is bone morphogenic protein.
Okay.
It's made in your body. That's what your body uses to heal bone. So scientists were
They
able.
invented that in the lab?
So the scientists were able to recreate that using recombinant DNA technology and make it in the lab.
Wow.
And so, we involved in the study way back when, looking at it for post-lateral fusions, and so now it's available, to be used for surgeons. And so we don't need to take iliac crest bone graft anymore. We usually mix it with local bone from the site and mix it with.
Does a
BMP.
patient ever reject that?
There's been no studies, to my knowledge, that have shown any type of rejection.
Nice.
Because it's made in the lab, it's recombinant DNA, and it's not an allograft where it's not donated from another body.
Did they ever used to do that? Like cadaver bone?
Sometimes they use allograft bone. It's usually morsellized.
Why would they use that and not this?
I mean, nowadays, most people will use either BMP or some other type of substitute. Occasionally, if you need an extensive amount of bone graft, you may need to add allograft bone.
Okay, gotcha. Okay. So in the last show, we spoke about osteoporosis. And with osteoporosis, especially in older people, the vertebral bodies, the bones of the vertebra, they become very brittle and soft, and the slightest of fall or movement or heavy lift will actually compress that vertebra. Sometimes we've seen them on X-ray, they're half the size of the vertebra,
Oh, yeah.
a quarter the size of what the vertebra should be. And sometimes instead of you seeing the bone that thick on an X-ray, it's now this thick. It's totally compressed. So Dr. Alangi does a technique called kyphoplasty,
Yes.
which is a technique to kind of like put material back in that bone, right? Am I correct?
Yes.
How does that work?
Like you said, some older patients, they get osteoporotic, the bone gets thin, and the littlest movement, somebody just bending over, picking up something off the floor, and it's that axial pressure just takes the vertebra, which was a square, and now it's a triangle or like a pancake. And it's very painful. Some patients who have a compression fracture, if they're not too uncomfortable, you can treat them in a brace and give it time and allow it to heal up. Some patients have a lot of pain and really have a hard time mobilizing, and that's the patients who be candidate for kyphoplasty.
And what exactly do you do when you do that? How does it work?
So yeah, it's a percutaneous procedure. It's a little tiny stab wound, probably like eighth of an inch. We go into the bone, put a little tube, probably like the size of the tip of the pen, put it into the vertebra, and once that tube's in place, it's a balloon. So it goes through that tube into the vertebra.
You're putting a balloon right in the bone.
Yeah, inside the
Wow.
center of the vertebra. The idea of the balloon is to try to restore some of the height of the
Blow up the
vertebra.
bone again.
And also, and that balloon's taken out, and then once that balloon's taken out, we put bone cement. And the bone cement kind of fills all the cracks and interdigitates with the bony spicules, and it helps maintain that, reduced state and helps with the patient's pain.
So does that procedure just stabilize, or does it actually make the bone bigger again?
I mean, majority of times it's stabilizing, but ideally, if you get it acute enough, reach enough fracture, you can restore some of the height.
You've seen that.
I've seen that, yes.
So it's better if, so am I right to say that if somebody has a new compression fracture and they're osteoporotic, that the faster they get this procedure done, the more successful it is?
Well, I mean, that's correct, and also for pain management, because the problem with these fractures, patients become bedridden, and there's a downward spiral from there.
Right.
So it's really good for pain management, hopefully to restore some of the height and help improve that quality of life.
Right. And I've seen in my practice many times people have these compression fractures where the bone, if we're looking at the bone from the side now, and the whole front of the bone collapses like this, and now instead of the bone being square, it's wedge-shaped like a triangle. The bones above it now have to follow that wedge.
Yes.
And instead of the person walking erect, let's say if they have that fracture between their shoulder blades, now they start to round their shoulders over, and now their neck has to go like this. So it causes all kinds of deformities above that fracture, which that then can create other problems above that area, right?
Oh, yeah. I mean, the hope is if you can restore some of the vertebral body height and their alignment, you avoid some of those issues. What tend to happen, like you said, like they get a rounded back, and now that makes it prone for other vertebrae to fracture because there's a lot of stress going through those other vertebral levels.
Do you find that if you do a low back surgery, let's say a laminectomy and fusion of, let's say, L5S1, by the way, that's the last of two vertebrae, the last vertebra in the back and the sacrum, and you fuse that, because I know the L5S1 disc is the biggest in the spine, do you find that there are sometimes now when the disc above that goes because it's not as big as the one below, and now that's got to take all the force?
Yeah, we do see that occasionally. It's a small percentage of patients, but it does occur.
Yeah? Okay.
Say L5S1 is fused, puts a little more pressure on the disc above,
Right.
and that disc may not be great to begin with, and then it
Right.
just starts to degenerate a little quicker than
So,
usual.
in our office, if a patient has had that surgery done, very important that if they're overweight, we get them on a weight loss program to take the pressure off the lower spine. Very important. We have them take the right nutrients so the bone can heal properly, minerals, vitamins. Very important that we get them on a good exercise regimen to strengthen the core. So those discs above that area don't have as much pressure on them as if they had a good, strong core. All these things are very important in our multidiscipline practice, where we treat the whole person from the head to the toe. Do you agree with that?
I agree. It's
Yeah.
very important, especially after spinal surgery, is their rehabilitation.
Right.
Strengthen their core, help build their muscles in their trunk to help just stabilize that segment and prevent
Right.
any adjacent level issues.
Right. And a lot of people think that after surgery, they can't see a chiropractor anymore. That's definitely not true. A chiropractor, if he has any type of brain on his shoulder, in his head, is not going to try to work on an area that's been operated on or fused. But the areas above that, if there are any problems with the areas above that, that's where the chiropractor will work on in order to prevent further, misalignment or
Yes,
distortion.
there's no reason why a patient who had surgery can't see a chiropractor.
Right.
A lot of my patients do see chiropractors, and it helps them out a lot.
And
Helps with
it's
adjacent levels.
interesting because, as you know, I do a procedure called manipulation under anesthesia or stretching under sedation, and we've had a lot of great success on post-surgical spine patients, which, as you know, after surgery, they develop adhesions, they develop scar tissue, and we're able to very gently stretch them out in the OR, which gives them more function afterward.
Oh, yeah, I'm sure it's very helpful for this
Yeah.
certain patients.
What are interspinous devices? I've heard that term before. What is that?
So patients with stenosis, there's not a lot of room for the nerves, like we spoke about. Interspinous devices is a device that's implanted between the spinous processes. And what that does is it opens up the space in between the spinous processes, and that opens up the foramen where the nerves are and helps get some of the pressure off the nerve.
Wow, I've never heard of that. That's really interesting.
Yeah, so it only opens it up, the canal, like a few millimeters, but for some patients, that's all they need.
Right.
And for some patients who can't have a more formal laminectomy, it's a more minimally invasive type procedure. It's a small incision.
How do
Just
you
go
attach
down.
those devices to the bone?
They have certain clamps that attach to the spinous processes,
Huh.
and it helps, keep it wedged in there.
Yeah, can we see slide number 1 again, please? Slide 1. Yeah, if you look at the diagram on the left-hand side, on the backs, on the person's back, you'll see those little bones popping out, going up and down. Those are called the spinous processes, and Dr. Alonji is talking about putting these devices between them to actually open up the spaces between the vertebra to get the patient some relief from the nerve pressure that they're having.
Yeah, and there's a few devices out there that allow you to do that, and they're very successful. Occasion with time, additional bony growth will come, and it'll kind of re-stenose the area. But for the majority of patients, they do
Is
well.
that like an alternative to disc surgery, or is that?
It's alternative to a formal laminectomy. So a
Okay.
patient who really can't tolerate a long surgical procedure, it's probably takes 30
Due to
minutes.
the health
procedure.
or whatever?
Exactly.
What's the recovery from something like that?
Typically, because usually older patients tend to keep them overnight just to watch them, but they're up and about the next day.
So you do your procedures in a hospital, right?
Yeah, all our surgical procedures are done at a hospital.
What hospital do you work?
Majority
what
of
hospitals?
our surgery is done at Huntington Hospital.
Okay.
We do a small amount at St. Catherine,
Okay.
Siena, and Smithtown.
Okay, cool. All right, so I've heard a lot about disc replacement surgery, where they actually put like a prosthetic disc in. Can you tell us about that?
Yeah, recently, in terms of new advances, disc replacement is definitely one of them. It's really developed over the last several years. They have disc replacement for the neck, and they also have disc replacement for the lower back. The idea is the disc is painful. You take out the entire disc and you replace it with a synthetic disc. So it allows motion, helps with patients' pain, and hopefully will prevent any adjacent level problems.
What is that disc made out of?
There's a few of them. Some are all metal, like titanium. Others have a high-grade plastic, just to kind of, for articulating surface. So there's a few discs out there.
And is that relatively new, or is that been around
It's
a
been
while?
out for a while.
Do you do that in your practice?
We do that. There's very limited indications. It's hard to do on a patient who had previous surgery at that level. If the disc is too degenerative, it's tough to do because you're just replacing the disc.
Right.
There's also facet joints at each
Right.
level.
Right.
So if the disc is severely degenerative, those facet joints are usually
Right.
degenerative as well. So if you just place the disc, it's not enough. And if there's any type of nerve compression, it's hard to do. So it is a good option for some patients, but not for everybody.
So what if it's like a young patient, they have a real bad car accident or a trauma, they have minimal degeneration, but they now have a big herniated disc? Would that be the kind of patient for that?
Yeah, if the height of the disc was good and there was a new onset disc herniation, yes.
Okay. So older folks that are osteoporotic,
Yeah, it's a little more
that
difficult
definitely
for
wouldn't
them.
be for them, right? Okay, so what is BMP, bone morpho? Is that's what you talked about?
We talked about that
before, right?
earlier. So
Right.
it's just a protein made in the lab, allows bone to heal.
Right.
And we've been using it pretty regularly for our
Right.
fusions.
Right.
It helped the fusion rates. It's been helpful for patients' recovery because we don't have to take their own bone.
Right.
And it's pretty much the standard right now.
Let's talk, our last topic for the show is stem cell therapy. Tell us a little bit about what stem cells are, where they're made in the body, what their use is, and the application in your practice.
So stem cells in spine is emerging right now. Stem cells is just a precursor cell that can differentiate into different types of tissue. And so a lot of times in the patient's body, they'll find it in their bone marrow or fat tissue. And there's different techniques to harvest stem cells from the patient's own cells or from donated cells. And so the idea with stem cell therapy is, it needs to kind of be an early degenerative process. Inject some stem cells into.
I'm sorry, early, I mean, somebody whose spine is degenerating
But
early?
early, if it's too far gone.
So it's not for a big herniation,
Yeah,
right?
and or if it's really like bone on bone, it's not going to work. It's really
Okay.
for the younger people who have early degeneration, some signal change in the MRI, but not a severe amount of collapse. So the idea is to inject the stem cell into the disc, help regenerate, the collagen fibers, the proteins that helps, rejuvenate that disc.
So stem cells then, I think, are cells in our body which grow and differentiate into different types
Exactly.
of tissue,
And
right?
helps draw in different factors from your body to help that healing process.
This might be a dumb question, but how do we know, I don't know how it works, I'm sure the audience doesn't know if I don't know, that the stem cells we take and inject into that disc aren't going to grow into ear cells, aren't going to grow into nose
Well,
cells?
it takes the surrounding environment.
Oh, okay.
And it kind of differentiates depending on the environment that it's placed into.
So whatever environment it's placed into, it's going to kind of like copy what's there.
Exactly, and it'll draw in different factors to help that healing process.
And it'll actually help that disc start to grow again.
Yes.
That's degenerated.
That's the goal.
Wow,
And
that's
it's been
pretty
very
wild.
encouraging in animal models. It's still, infancy in humans.
Yeah, we had an orthopedic surgeon here last week, the shoulder knee surgeon, that was talking a little bit about that, injecting stem cells into joints to help regenerate like cartilage and things like that. And
Yeah, it looks very promising.
so are they actually doing this yet?
Certain stem cells, there are a lot that are still under clinical trials for the spine.
You haven't done any of this yet?
No, I'm getting involved in a clinical trial for that, but we haven't done it yet.
Interesting. Okay, so again, your office, where is your office located again?
We're
Dr.
at on Jericho Turnpike, 206 East Jericho Turnpike in Huntington Station, New York.
Right. And I want to tell the audience, this office is like state-of-the-art. I mean, they have MRI, CAT scan, X-ray. They have a full OR where they do pain management. And the team there is awesome. And we refer to Dr. Alongi very, very often for his, not necessarily because we think a patient might need surgery, but just to get his professional opinion and to be part of our team in treating a patient. Dr. Alongi, again, I might be putting you on the spot, but what's the most challenging patient you've ever treated? I mean, really, where you scratched your head and said, what am I going to do for this patient?
I don't know. Every patient that comes to the door, you want to try to do the best you can for the patient.
Right.
And there are just some patients that, the surgery went well, the X-rays look great, the fusion looks good, instrumentation's good, but they're not doing as well as you would like. Those are always difficult patients, professionally and personally.
Right.
Because again, we want patients to do well.
Right.
So those patients, again, we try to reassure them. We don't just, brush them off like there's nothing else we do. We keep trying
Right.
trying to help them out,
Right.
whether it's
Right.
different modalities, whether it's pain management.
Right.
And keep, at it to try to get the best outcome we can.
It's really funny because when I first started practice in 1984, sorry, yeah, I am that old. In my second year of practice, I had a patient come in to me, and he was about 85 years old. Low back pain, problems urinating, bowel problems, and I x-rayed his lumbar spine, and I looked at it, and I said, this was right out of school, 2-3 years out of school, and I looked at it and I said, oh my God, what the heck am I going to do for this guy? I mean, there was arthritis everywhere, things were fused. And I said, in my report of findings to the patient, I said, look, I don't know if I can help you. I said, I'm willing to give it a shot, but
Sure.
I can't give you any guarantees. I said, my job is to try to get the nerves freed up as best as I can. And then we're going to see what happens after those nerves are freed up. If it helps you, fine. If not, I can't guarantee it. So I started treating this patient, and within 4 weeks, all of his symptoms went away.
Wow.
He was urinating well, his bowel movements went well. And after that happened, I said to myself, as I graduated valedictorian in my class, so I was very book-oriented. I said to myself, I'm never going to judge what the innate healing ability of the body is.
Oh, it's amazing.
Because I'm sure you've seen in your practice where you don't think people are going to respond. You're like, wow, I can't believe how well this patient's doing, and vice versa.
Exactly.
Where you think patients are going to do well, and there are other factors that are out of our control as doctors sometimes, which is maybe a reason why they're not doing as well as they should, that they don't tell us.
Sure.
Or maybe it just wasn't meant to be. But again, our job in our facilities is to try to do the best we can, humanly possible, to try to help you, the patient. Again, our offices are located in Melville, Hicksville, Medford, and Ronkonkoma. And Dr. Rolangi is integral part of our team in helping our patients. I'd like to thank you again, Dr.
Thank you very
Rolangi,
much.
for joining us. We'll have you back soon, I
All
hope.
right, great. Look forward to it.
And for those of you watching, thank you for watching our show. We'll be back next week, and have a great day.